You are welcome to this important topic of pseudo dementia masterclass, clinical skills in psychiatry. It's an important station which occurs in the CAS clinical examination skills. I'll give a hypothetical station. The task is you are asked to see a 70-year-old man in your outpatient clinic. His wife died 8 months ago. Since then, he has not been his normal self. He has been confused and forgetful. Your task is to get relevant history and assess his mental state and come to a diagnosis. You are not expected to assess cognitive functions. So in this presentation, I'll talk about some examination skills to start with. The task in this station is to get relevant history from the patient in relation to bereavement, depression, which is pseudo dementia, and dementia. This station involves structured history taking, including the following: onset of symptoms, cause of illness, depressive symptoms, including biological symptoms, the meaning these symptoms hold for the patient, that is, relation between these symptoms and the loss of his wife. Any psychotic symptoms, are they in the context of losing his wife? Cognitive difficulties, onset, progress, vascular symptoms, neurological symptoms, sundown effect of the symptoms, personality change, including emotional incontinence, disinhibition, and irritability, social changes, including social isolation, lack of attendance to financial issues, substance misuse, etc. It is good practice to summarize the findings in the last 1 minute of the station and give a working diagnosis. Now, some notes on pseudo dementia. Features include depressed affect or mood, neurovegetative signs, which are somatic symptoms, slow, spontaneous, monotonous speech, and long response latencies, frequent I don't know responses, quick to give up, but can be encouraged to complete the task. Disorientation, impaired attention and distraction, incomplete responses or forgetfulness, particular deficit in learning new information, although memory may be patchy, poor abstraction, typically makes error of omission versus error of commission. Awareness of cognitive difficulties may have concern over deficits. For example, do I have Alzheimer's? C, I can't remember anything. If psychosis, delusions typically nihilistic, self-depreciatory, and paranoid. No signs of aphasia, apraxia, or agnosia, with greater similarity to subcortical dementia, such as Parkinson's. Now, a bit of statistics. Between 2 and 32% of older individuals with cognitive impairments actually have pseudodementia. However, this number may not be completely accurate because it is often tricky to distinguish between depression and dementia in older adults. A thorough clinical interview and assessment may reveal important clues to narrow the differential diagnosis. Although pseudodementia is reversible, management can be very complex, requiring flexible biopsychosocial approach. That is the treatment. Psychotherapy aim is either individual or group therapy to help manage or reduce depressive symptoms. Cognitive behavioral therapy or CBT and interpersonal therapy IPT are two types of therapies for depression that have been shown to be successful in studies. CBT involves modifying a person's unhealthy behavior and thinking pattern. IPT focuses on understanding personal relationships and their role in causation and maintenance of depressive symptoms. This condition is important to diagnose as pseudo dementia and treat as the deficit is at least partially reversible. And the patient will also need further investigations for dementia. In the next series, we'll talk about grief. And thank you for your time, and I wish you all the best in your career. Bye for now.